Hey guys, so today we're going to be talking about Turp, which is transurethral resection of the prostate. The prostate is removed during a resectoscope that is inserted through the urethra. The A&P you will need to know for this procedure is the bladder, which is a trigone shape, hollow and muscular. Its job is to store urine, and there are two layers of the bladder, the outside layer, the adventitial layer, and the inside layer, the urothelial layer. The ureters, which are tube structures that carry urine from the kidney to the bladder neck, which is a group of muscles that connect the bladder to the urethra, and the neck fills with urine, which tightens and holds the urine into the bladder. The arterial supply for this includes the superior, middle, and inferior vesical arteries. The venous supply drains into the internal iliac vein, and the lymphatic system is served from the vesical, internal and external iliac, and common iliac lymph nodes. The prostate, a walnut-sized gland that sits between the bladder and the penis. It is usually 4 centimeters at the base and 2 centimeters in depth, and it is located at the base of the bladder neck and surrounds the urethra. Its function is to secrete a prostate fluid, which is a component of semen. There are 4 glandular regions of the prostate, which are located within 2 zones. The major zone, which includes the peripheral zone, and the central zone. And then you have the minor zone, which includes the transitional zone and the periurethral zone. The prostate lobes secrete alkaline fluid, and the posterior lobe of the prostate is palpated during an exam, and cancer is prone to this area. A fibrous sheath is located behind the prostatic capsule, which separates the prostate gland and the seminal vesicle from the rectum. The arterial supply for the prostate is derived from the pudendal, inferior vesicle, and hemorrhoidal arteries. The pathophysiology for this would be an enlargement of the prostate that is either related to infection, benign tumor, or malignant tumor. The cells multiply and grow into the urethra, causing an obstruction. Also, a benign prostatic hyperplasia is commonly treated by this procedure, a resection. The anesthesia for this procedure would be general, spinal, or regional anesthesia. The positioning would be lithotomy, and the skin prep would go cleansing the pubic area, extending from the umbilicus to the middle thighs. The anus is prepped last, and each sponge should be discarded after each wipe. Draping would be a urology drape with a rectal sheath, and supplies for this would be a resectoscope, Elkin evacuator, stabilized or unstabilized cutting loops, post-resectoscope with its sheath and the articulated obturator, a high-frequency cord, a short bridge, a Toomey syringe, 3-way Foley catheter, disposable urology drape with rectal sheath, a system for continuous bladder irrigation and urinary drainage. The equipment needed are SCDs, a bear hugger, a bipolar ESU, high-flow fluid warmer for irrigation, fiber optic light source, and cystotable knee crutches or padded stirrups. The instrumentation needed for this would be a sterile screen, a rigid fiber optic cystoscope, a resectoscope, a bridge required for the telescope to fit into the sheath, a stopcock, hemostats, and catheter nipples, and a penile clamp. During this procedure, continuous irrigation is used to maintain a clear view and to evacuate small pieces of tissue. The resectoscope is constructed with an outer sheath that allows fluid to flow out of the instrument. So to begin this procedure, the surgeon will lubricate the cystoscope and insert it into the urethra. The obturator then is removed, allowing the bladder to drain. The CST should be prepared to collect urine at this point for a sample to be sent for analysis. Irrigation fluid will then be instilled into the bladder. The bladder is assessed and the cystoscope is removed. The urethra will then be dilated with Van Buren sounds. The resectoscope is inserted and the resection begins at the middle and lateral lobes and continues into a systematic pattern. Small pieces of tissue that are released into the irrigation fluid will then be evacuated with an Elkin evacuator or a Toomey syringe. As the CST, you must retain all pieces of specimen for the pathologic exam. Then, at the end, a 3-way Foley is inserted after the resection is complete and the bladder is fully irrigated. There is no dressing needed, and the specimen would be the pieces of tissue from the prostate. This would be considered a clean, contaminated case.